welcome to the Derm Club podcast. This is a community where we are trying to simplify skincare. And here at this podcast, we bring on the world's leading experts like you to talk about skincare related topics that we find interesting and we believe are relatable to everyone in this population. So welcome. So today we're going to talk about a big skincare topic called psoriasis. I think you're familiar with it, which is a chronic cutaneous inflammatory disease that affects 125 million people around the world. And more than 8 million people, more than 8 million Americans, We know that psoriasis is searched close to 1 million times a month on Google and in the United States. So we certainly know that this is a hot topic and something that interests a lot of people. I'm very fortunate today to have Dr. Stephen Feldman here with us, a board-certified dermatologist from Wake Forest in North Carolina, who is one of the leading experts in psoriasis in the world. He sits on the national board of the medical board of the National Psoriasis Foundation, which I actually am a member of. And he is a prolific researcher in psoriasis with over 800 publications in just the past 20 years. So he's very impressive and he's an expert. If you have psoriasis questions, he is your go-to. I'm excited to have you here on the Derm Club podcast today, and welcome.
My pleasure. It's exciting to be here.
Great. So let's just get started really simple. What is psoriasis?
It's not so simple. I think it said that psoriasis is a lot like pornography. You know what the Supreme Court said about pornography, right? You
No.
may be too young. Yeah, they defined it, but they said, we know it when we see it. And psoriasis is very similar to that. It's not like diabetes, which is easy to define. Oh, you don't have enough insulin action. That's diabetes. Psoriasis is these red, scaly lesions. They have very sharp borders. They have a white scale on top. They're thick. And they involve characteristic areas like the scalp, elbow, front of the knee. They could be anywhere between the cheeks and, on the backside, in the belly button. Palms and sole involvement would be severe, but it's hard to define. There's probably a lot of different genes that are related to it, but dermatologists recognize it when we see it.
Okay, so it's kind of easy, like someone walks in the room and you just almost know, like, oh, you have psoriasis.
Yeah, I think a lot of dermatology is like, at least diagnostically, is like looking at a helicopter or looking at the Mona Lisa. There are a lot of different kinds of helicopters, different sizes and shapes and stuff, but if you've seen one, you've seen them all. A helicopter when you see it. Your mind, says helicopter. And when you see this pattern of red scaly rash on the skin, I think to a dermatologist, they say psoriasis.
So it sounds like from the way you're presenting it, it has a lot of variability in the way it can present. It can be in the elbows, but sometimes it can just be in the scalp. Is that correct?
Absolutely. It's the variation is tremendous. A typical person with psoriasis probably just has some spots on their elbows and knees. If it's a little more severe than that, they probably have a little bit of at least dandruff that they may not realize is psoriasis in their scalp. And it can vary from that to just the total body being covered.
Right. So a lot of people have dandruff. Do you call that psoriasis, or is that a different condition?
Oh, that's a great question for your audience. Dandruff means scale falling out. It means you can't wear dark clothing because you'll have little white specks. Psoriasis can cause dandruff. Other things can cause dandruff, the other common one being seborrheic dermatitis, which is a greasy, scaly rash people get on their scalp and their eyebrows, side of the nose. Sometimes it's hard to tell psoriasis of the scalp from seborrheic dermatitis when those are the only areas involved. Right. If you see that dandruff and you're wondering, is this psoriasis or not, you could look for signs of psoriasis on other parts of the body. And one of the cool places to look is in the fingernails. If there's little tiny pits in the fingernails, that could be signs that it's psoriasis. That would be something that seborrheic dermatitis doesn't do.
I understand. So are there different types of psoriasis? I know just from my time in my clinical experience, there's guttate psoriasis, plaque psoriasis. Can you talk to me a little bit about the different types that you are likely to see? And then what is the most common type that a patient might walk in the door and have?
Yeah, I think the answer to the question, are there different types, is yes and no. On the one hand, we could split it up so that when you have typical psoriasis on the elbows and knees, we'll call that plaque psoriasis because those are plaques. Uh, if there's little tiny plaques of psoriasis all over the body, you could call it guttate psoriasis. If the plaques are studded with pustules, you could call that pustular psoriasis. If it's psoriasis of the palms and soles, you could call it palmoplantar psoriasis. If it's in the underarms, in the groin area, you could call it intertriginous psoriasis. Or if you wanted, you know those little tiny plaques of psoriasis that some people call guttate psoriasis? I actually call that a form of plaque psoriasis in a guttate pattern. All psoriasis, if you look microscopically, has pustules in it. So that what we call pustular psoriasis, I would just call that a pustular variant of plaque psoriasis. Palm and sole psoriasis, palmoplantar, I would call that plaque psoriasis of the palms and soles. And the reason I do that is because the only treatments that we have approved for psoriasis, at least the new modern ones, are approved for plaque psoriasis. And if you claimed that it was a different kind of psoriasis, the drugs wouldn't be available to the patients. And so whether you call these different variants different versions of psoriasis, or you just call them different versions of plaque psoriasis, has clinical implications. But there's no real definition. There's no proof that, the guttate version is a distinct disease from regular plaque psoriasis.
I understand. So, what is the typical age presentation? Is there an average age where you start to see psoriasis pop up, or it can really vary?
I think it commonly appears in adults. It was probably most commonly in your late 20s, but it can occur really early in life, or it could occur late in life.
So, is this a condition that if you wait to treat it, it will flare and get worse? And you encourage people to jump in early and treat early, or it doesn't really matter at what point you treat it because it's still going to be the same outcome?
That's a great question. I don't think we have the science to know the answer to that.
Okay. So, do you know anything about the genetics behind psoriasis, or is that something scientifically that's still being discovered?
Oh, it's an awesome area of research, and we know a lot of the genes that are related to psoriasis. I saw one study that involved enormous numbers of patients, evaluation of enormous numbers of genes, and I think they found, I can't remember how many hundreds of genes that were linked to psoriasis, and that only accounted for like 30% of all the variability in psoriasis. And so I think there's a lot more to know. I think we found the common things. There's genes of the immune system that are linked to psoriasis. So we know psoriasis is an immune disease. And some of the signaling molecules of the immune system, a signaling molecule called interleukin 23, the genes for that and for its receptor are linked to psoriasis. So in some ways, I think when I treat by giving a patient an interleukin 23 blocker, for those patients, I may be getting to the root cause of their disease.
Interesting. So, do patients with this interleukin 23 disease usually have other diseases that they present with, or is it just solely psoriasis?
So the genes for interleukin 23 are linked to psoriasis. They're also linked to this condition, psoriatic arthritis. It's very common for people with psoriasis to have joint pain, stiffness, to have inflammation in their joints the way they have inflammation in their skin. And the IL-23 genes are also linked to inflammatory bowel disease. So you can have inflammation in your colon, in your GI tract. These diseases are linked. So it's not surprising that because interleukin 23 is involved in all these diseases, that people with psoriasis may commonly get the arthritis and or its increased risk of having the inflammatory bowel disease too, although that's much less common than the arthritis is in psoriasis patients.
Fascinating. So I'm assuming that some of these therapeutics can likely kill let's say, three birds in one stone. They can treat rheumatoid arthritis, the psoriasis, and the inflammatory bowel disease, right?
That's absolutely right. So we have some treatments that are approved and proven to work for all three. You would think that if a treatment will make psoriasis better, it will make these other inflammatory diseases better too. And that's pretty much true until they got to this other signaling molecule, interleukin 17. It works great for psoriasis, maybe the fastest acting way to clear psoriasis completely up. I remember when my partner was doing the studies on blocking interleukin 17, he came to me and said, I've never seen anything like it before. These psoriasis patients completely clear. And they thought, well, it's going to work great in arthritis, and it does. And it's going to work great in inflammatory bowel disease, and it doesn't. In fact, it may make inflammatory bowel disease worse. The immune system
Fascinating.
is inscrutable, unpredictable.
That's fascinating. So I get this question a lot. Is psoriasis contagious?
Well, for the most part, no. However, if you were to get a bone marrow transplant from somebody who had psoriasis, yes, you could transmit psoriasis that way, but that's not our usual way of thinking about contagiousness. No, if you rub somebody else's psoriasis, you can't get the disease. In fact, I remember when I was a medical student, I got to work with Dr. Calloway, who had been the former chair when I was a medical student at Duke. He had been chair of the department there. In fact, he had been president of the American Academy of Dermatology, if I'm not mistaken, back in the 1930s. He could barely see. You know, I think he would smell things to know what they were at this point in his life. And when he would see a patient with psoriasis, he would put his hands on the psoriasis and he would say to the patient and their family, as he put his hand on his face, this is no disease. This is nothing I can catch from you. Addressing patients' social anxieties about their psoriasis was critically important to him, because back in those days, we didn't have any of these modern miracle treatments. And so we could get people a little better and make them feel comfortable about having psoriasis, but we couldn't clear their disease like we can now.
Right. It's amazing where medicine has come, you know, how far it's come. So what other diseases can psoriasis be mistaken for? I'm sure it looks and presents like many other conditions and
Oh,
maybe
gosh, yes.
misdiagnosed by some.
Yeah. You know, if you look at the red scaliness of psoriasis, it looks a lot like a fungal infection. It can get in the nails like a fungus can. In fact, if you did a biopsy of psoriasis and a biopsy of a superficial fungus like an athlete's foot, the biopsies would look identical, except the fungal infection would have the presence of fungus in the biopsy. In fact, sometimes I think what psoriasis is the body's pathway for fighting off fungus being activated when it shouldn't be.
Wow, I
So,
never knew that.
yeah, so some forms of psoriasis might look like a fungal infection. Sometimes maybe it's not as scaly or thick, and it might look more like a contact or allergic dermatitis or an eczema. Sometimes when you have those little spots all over, well, there's a condition, pityriasis rosea, that can cause little spots all over that comes up, lasts 3 months and goes away. But distinguishing that from gut tape psoriasis would be tough. I think probably psoriasis could look a lot like syphilis, or syphilis could look a lot like psoriasis. I think that's why they say, you know, a dermatologist is a doctor who, a dermatologist is very easy. If it's dry, wet. If it's dry, wet it. If it's wet, dry it. If you don't want it, don't touch it.
I hear that all the time. So do you find yourself biopsying psoriasis often or not so much?
I don't biopsy psoriasis very often at all. And I'm in a setting where we get the weird cases. So even in a setting in academics where you're getting the odd cases, you rarely have to do a biopsy for psoriasis. You usually know it when you see it. And I think it's even less common to do a biopsy in other settings.
At what point in time in someone's life do patients tend to come in to seek help for their psoriasis? I mean, I know I have friends who have psoriasis, and I don't think they've even been to a dermatologist because they're like, oh, it's not so bad, I can manage it. But
Yeah.
I imagine that at one point or another, it becomes frustrating enough or a nuisance that they want help.
It's so great that you have friends. That's awesome. You know, uh, the, I think dermatologists believe that everybody with psoriasis goes to the dermatologist because, well, that's who we see. We see all the ones who come to the derm. We don't see the ones who don't come to the dermatologist.
Right.
And I think most people with psoriasis don't go to the dermatologist. I base that on a really good study that the National Psoriasis Foundation did of how many people there are in the United States that have psoriasis. And there's something like probably 6-7 million people with psoriasis in the United States. And then there's other studies my buddy Alan Fleischer did using data from a representative survey the federal government collects called the National Ambulatory Medical Care Survey. He found that there's only about 2 million visits to the doctor for psoriasis in any given year. And if the average person who goes twice, that means there's only 1 million people in any given year seeing the doctor, which means that 6 out of the 7 million aren't going, you know? So I think there's a lot of mild psoriasis out there, people who aren't particularly bothered by it or have figured out a few things they can do without even going to the doctor to make their psoriasis better.
Right. So do you think a primary care physician is likely to diagnose psoriasis?
No, of the 2 million office visits for psoriasis in any given year, I think 80% of them are to dermatologists.
Oh,
Uh, and there's only like, I don't know, 10,000 dermatologists, and there's probably like 100,000 primary care doctors. So you've really taken that 20% of psoriasis patients and you spread them out among lots of non-dermatologists. And I suspect those 20% of visits that are to the non-dermatologist, a lot of the time, the patient has already seen a dermatologist, they have a treatment plan, and the family doctor is just refilling the dermatologist's medication. So family doctors may care for some psoriasis. They may sometimes make the diagnosis, but I think most of the time they don't. That
so I
one
can.
study we did some years ago, we looked at how likely a family doctor would be to refer a patient to a specialist.
Mm.
If a patient has diabetes or heart disease, the family doctor is less likely to refer the patient to a specialist than they are if the patient has a skin problem like psoriasis. If the patient has a skin problem, primary care doctors largely, I think, are like, no, you need a dermatologist.
I think they are trained more in diabetes, heart disease, and less in skincare. So it makes sense.
Yeah.
It's good to see an expert like yourself. So I want to ask you about a hot topic related to psoriasis, which is diet. I worked in many clinics, hair clinic, psoriasis clinic, and we always had patients coming into us and say, what is there a specific diet I can be on to stop this? So what is your take on the relationship of psoriasis with food and what you eat?
Yeah, I don't think there's any specific foods that make psoriasis worse in general. But if you found that every time you ate yeasty stuff, you get more psoriasis, okay, cut back. Uh, I, there have been a number of trials of diet in psoriasis, and for the most part, they didn't show that any particular diet was very effective. I think maybe if you took massive quantities of fish oil, maybe you would get a little improvement, possibly.
Why
There
fish
was,
oil?
huh?
Why
I
fish
think,
oil?
yeah, I think the immune system uses various kinds of oils to create signaling molecules, and the fats that are in the fish oil get converted into less inflammatory signals than the normal fats in an American diet.
So
I
do
think
you encourage your patients to take fish oil or only
no,
if they're
no, I
taking
don't.
it?
I think it would take enormous quantities to where you smell like a fish with your breath to get even a minuscule change in your psoriasis. I would.
Okay.
There was one study that did show that a strong calorie restriction diet with weight loss made psoriasis better. Now, it could be that if you poison the immune system by not feeding it, psoriasis gets better. Or it could be that when you put people on a diet that is that restrictive, that people have to regiment their lives to follow the diet, then they become, then they use their medicines that they've prescribed better. That regimenting somebody's
Are
life,
more compliant.
they're more compliant to the treatment that was recommended, and that could make them better. So I don't know that even calorie restriction, but if you're overweight and you need to lose weight anyway, okay, fine. It's probably not a bad
Right.
idea.
I actually remember this past year seeing a patient. She came in with her mother. She was a very young girl. I think she was autistic, actually. And they had her on an extremely strict diet where she was calorie restricted. She was only allowed to eat certain foods. The mother showed me a journal of what she's allowed. And she said that ever since doing this diet, she said she had been on every biologic, every medication known to mankind. Nothing helped until she did this. So it is really interesting to know, is it because they're just more compliant with their medication because they're on such a regimented schedule?
Yeah, it's interesting at so many levels
Yeah,
because, you know, it's interesting because of the diet. It's interesting because of the regimentation of the life and how that might affect compliance. It's interesting because it could be that her psoriasis was going to go away anyway, and it just happened to happen at that moment. But most interesting to me is that it's a story, and the story of one patient has an enormous impact on the way humans think. Um, you can give a human all the data on something, all the evidence that diets don't work, they've been tested, but then you tell them one story about, well, this diet worked for this person. There's a good chance they will try that diet, you know? And I'm,
definitely.
yeah, I am the nerdiest person in dermatology, the most data-driven person. I'm trained as a protein chemist. I don't have social skills. I was doing CrossFit with the young people and blew out my back. And it was the most intense pain I'd ever experienced. And I was up all night because I couldn't sleep. I was writhing in pain. So to distract myself, I'm reading about how back pain should be treated, the sciatica. I read Up to Date, which is this online textbook that tells you, you know, what the most up-to-date information is. And Up to Date said, just do physical therapy. You know, the other things like surgery, steroids don't help in the long run. I read the articles that Up to Date was based on. I did my own literature searches. And I read the data. All the data said, just do physical therapy. Don't do surgery. Don't take steroids. I'm like, fine. I'm going to have to live with this. I'll do the physical therapy. And I was, you know, really good about doing the physical therapy. And I was slowly improving to the point where I could, you know, function. I could walk between patient rooms. They didn't have to wheel me around from room to room. I go to work one day and I talk to my buddy, the surgeon, the skin surgeon, and he says to me, Steve, I had a disc problem in my neck. It was affecting my hands. The neurosurgeon gave me prednisone. I took it and my function improved immediately. Okay. Again, I'm the most data-driven person on the planet. I've read all of the research proving that steroids don't work. The steroids in this guy, his hands are probably going to get better anyway. Certainly in the long run, there's no proof that. When he told me that story, I was on the phone to my gerontologist immediately demanding steroids for my back. One story. If I want a patient to take a medicine, I could give them all the evidence, all the data, the efficacy, the safety, everything we know about it. Or I could just tell them, you know, I had a patient whose psoriasis was a lot like yours. They did really well on, and I named the drug. That one story is more impactful on their thinking than all the data.
The human mind is amazing, right?
It is amazing.
So, is there a positive correlation with obesity and psoriasis? Now that we're talking about data, and I'm sure you know the data behind the connection between obesity and psoriasis, if there is one.
Yeah, well, I think people with psoriasis tend to be more obese. There's a lot of obesity in Americans with psoriasis. One of the interesting things is there's a lot of obesity in Americans. And so I don't think obesity causes psoriasis, although there may be some evidence that in young children who are obese, they are more likely to get psoriasis. So, but the other thing is if you have bad psoriasis and your joints hurt, and you're embarrassed by how you look, you may be less likely to go to the gym and exercise. And so it could be obesity has behavioral effects that would make psoriasis worse, and psoriasis could make obesity worse. And there could be some shared genetics. It's a really complicated area.
Got it. So does psoriasis affect all skin types, or like one population more than another?
Yeah, if you look across the world, there are higher rates in different areas, and part of that could be differences in diet. Within the United States, there's some evidence maybe that there's some uh, demographic differences based on race and all, but there was a study in the 1960s that was done that and it created a dogma that lasted many years. It was in all the textbooks that psoriasis occurred in whites but not in blacks. The way they did this study is they got dermatologists to send the investigators a postcard. Every time they saw a new patient with psoriasis, they'd fill out a postcard letting the investigator know the demographics of the patient. And what they discovered, the investigators discovered, is everybody with psoriasis was white. Well, what it meant was everybody with psoriasis who saw a dermatologist was white. And there's plenty of psoriasis in African Americans, but they, at least in the 1960s, they probably weren't getting to the dermatologist as often.
I understand. Okay. Interesting. So, what is the goal of treatment when someone comes in and they say, I have psoriasis, I'm really itchy? Do they present with usually, what are their common symptoms, first of all?
Yeah, they have red scaly lesions, and they're itch, that these lesions itch, they may crack and be painful. If they're on the palms and soles, it may limit people's ability to work or even walk. I think the people might be complaining about the dandruff and limiting what they could wear.
Right.
It could be that they've got spots on their legs and they're women and they feel like, I can't wear a dress. Because I have a picture of the folks from Good Morning America, and it shows like these three guys wearing slacks and these three women showing their legs. And it's, I think if a guy has psoriasis on the legs, probably doesn't bother him that much. If it's on a woman, it could be, especially an unmarried woman who wants to date, could be, psychologically devastating.
What are the typical treatment options that you can offer?
Yeah, so let me just answer your question about the
Yeah.
goals. What's the goal of treatment? I'm old-fashioned. My goal of treatment is to make people happy. The National Psoriasis Foundation said the goal of therapy should be to get people clear. Part of their reasoning is that there's some evidence that having the inflammation of psoriasis in your skin, in your body, affects you internally and can even cause you to have a greater risk of having a heart attack. In fact, if you're between the ages of 20 and 30 and you have severe psoriasis, you're like at a 3-fold increased risk of having a heart attack.
Wow. Because of the stress that it's causing to you and your
We
body?
don't know why. We think it's the inflammation in the body causing inflammation in the vessels that will actually worsen atherosclerosis and cause heart disease. And it sounds absolutely horrible until you ask yourself, well, no, wait a minute. What's the chance that a 20 to 30-year-old without psoriasis is going to have a heart attack? And the chance is roughly 0. Not exactly 0, but it's close to 0. You know what 3 times 0 is? It's like still pretty close to 0. So it sounds like this big risk. And I think to some extent it's blown up because dermatologists want to be able to treat our patients. And we're afraid insurers won't cover it because they'll think it's cosmetic. We know it's not cosmetic. We need to treat our patients. Well, having this data that shows that psoriasis causes cardiovascular disease, makes psoriasis more important, makes it so insurance will cover it. And I think it's led to people saying, wow, the goal should be to get people completely clear. I don't know that getting people completely clear changes their risk of heart disease significantly or not. But I do know I want my patients to be happy. So if I get to have somebody with horrible psoriasis and I get them, 90% better and they're happy, I'm happy. If I have a woman who's got psoriasis on her shins and I get her 90% better and she still has spots on her shins and feels I can't wear a dress, I can't show my legs and is completely unhappy, then I feel like I failed.
So what are the typical treatment options that you can offer to patients?
Oh, we have a slew of treatment options. Let's talk about two kinds of psoriasis. One kind is where people just have a few spots. For those patients, I can have creams and ointments and things like that that they can rub on their disease. For people who have tons of psoriasis all over, it's not practical to just use a cream. And I have ultraviolet light treatments and internal medicines. So if you just got spots on the elbow, you could use a topical tar product over the counter without even going to a dermatologist. Dermatologists could prescribe various forms of cortisone that are stronger than the hydrocortisone you can get in the office. There's vitamin D analogs that can work, vitamin A related creams that can be used.
Retinoids?
Retinoids.
So do
And
you ever find that people are, sorry, a little sidetrack, do you ever find that if someone has acne, they're using their retinoid products on their psoriasis?
I haven't noticed that, but it certainly could happen. And that could be of benefit to them. The retinoids tend to be irritating and not the most effective. They're kind of slow acting. So I don't use a lot of retinoids for psoriasis, not topical retinoids. And then you could do limited ultraviolet light with various devices to individual spots. The topical cortisone medicines are the basic way of treating it, and they come in various forms. So I was taught in dermatology, give patients ointments because the ointments will moisturize the psoriasis and they're going to be better, stronger treatments for the psoriasis. And then I came to realize a lot of patients hate putting greasy ointments on, and less messy things are available, like a spray, you spray it on, it's great. They make clear liquid solutions for use in the scalp. And if the spray is too expensive, a patient can take the clear liquid for the scalp, put it into a $1 spray bottle that they get at the dollar store and make their own spray for psoriasis. So a lot of options there. For people with extensive disease, I think ultraviolet light treatments can be a great treatment. And we have an ultraviolet light box in our office, or you can send people into the sun for their psoriasis. And I hope you don't cut me off here, but patients can go to tanning beds and get ultraviolet light that way. We dermatologists hate tanning beds. You know, they damage the skin. They make you lose your youthful complexion, leave you looking wrinkled and mottled earlier in life than what you would otherwise need to, get skin cancers. But if you had bad psoriasis and need light and can't come to the doctor's office or can't get a prescription home light unit, going to a tanning bed's an accessible, easy, low-cost way of managing psoriasis. And then there's the internal medicines. The old standard was methotrexate, a chemotherapy drug used in low doses to calm the immune system down. But now they have all these injectable medicines that you see advertised on TV that are much more effective and a whole lot safer.
So you don't really find yourself prescribing methotrexate as often anymore?
Oh, definitely not as often. I wouldn't want to prescribe it at all if I didn't have to. Sometimes there are some insurers, particularly government insurers, where they won't pay for one of the injectable medicines, one of these biologics, unless the patient has tried methotrexate and failed that first.
So could you talk to me a little bit about, because you mentioned light therapy as a great way to clear up someone's skin who has a lot of diffuse lesions on their skin with psoriasis. How does the light therapy work? What is the science behind that?
Yeah, we don't know. Light has enormous effects. There's probably tens of thousands of genes in the cells of the skin that are changing when you hit the skin with light. And so we don't know exactly how light works, but we can speculate on it. Light, I believe, kills the immune cells in the skin that are causing the psoriasis. And because of that, when you clear up psoriasis with light, there's a theory that the psoriasis tends to stay gone a long time. Well, because you've actually killed the cells that were causing the psoriasis. Exactly what steps are involved in the killing of those immune cells, who knows?
So, a lot of people and patients see commercials about different psoriasis therapies that are coming onto the market. So it can be confusing as to which one is the right one for each patient. What do you usually go for? What are the leading therapies that you're most excited about? And where do you see the future of psoriasis?
Yeah, I've been doing this long enough to have seen the revolution. When Embrel hit the market, it just revolution. It made patients so much better, so much more reliably, so safely. It was wonderful. I thought I'd never see such a quantum leap forward again. And then came Humira, which has almost the same safety as that Embrel, maybe not quite, but very close, and is considerably more effective. I thought, okay, no more quantum leaps after that. And then Stelara came out, which was more effective than, well, it was probably as effective as Humira in the short run, probably more effective in the long run, safer, and fewer injections. And I'm like,
Mm.
wow, I've seen it all. Then came these interleukin 17 blockers, which just cleared psoriasis so much faster, even more effectively than Stelara did. And then we got the newest ones, these IL-23 blockers. And with just a couple shots a year, basically, a few shots a year, they seem entirely safe as far as I can tell. And they may be, in the long run, the most effective treatments. They probably don't work as fast as those IL-17 blocking drugs, but boy, in the long run, they seem really good. So right now, even though Enbrel was revolutionary, I can't remember the last time I wrote a prescription for that stuff. It's been a while. It's approved in young children. I might use it there once, you see that come up. But these new IL-17 and IL-23 drugs are the ones I would rely on. And you could pick from any of these drugs because they're all great. If the insurer said, Steve, we don't practice medicine. You can prescribe whichever of these therapies you want, but you should know we only pay for Humira. I'd be like, fine, Humira's okay. It's a great drug. But I prefer the newest ones, the things like Tremfya and Skyrizi, and I'm almost as happy with things like Taltz.
What about Dupixent?
Dupixent is a great biologic for atopic dermatitis, but it's not approved for psoriasis.
Okay. So what about compliance? Do you see that patients have poor compliance? There are many patients who don't want to inject themselves frequently. Do
Yeah,
you
you
find?
could invite me back to talk about compliance because that is this enormous issue. In medical school, they teach us people, it's hard to get them to take pills. Getting them to rub greasy slop on their body a couple times a day for the rest of their lives, it's almost impossible. I was very fortunate. I was walking down the hall one day with one of my research colleagues, and he mentioned that there was a company in California that sold medication bottle caps that contain computer chips that will record the day and time patients open and close the containers. And I was like, they make what? I turned to my minions and immediately I said, I don't care what they cost. We have to find out what my psoriasis patients are doing with their medicine. And so we were doing a little study anyway. We're giving people some cream for their psoriasis. We put the cream in the bottles with the computer chips, and we told patients, put the medicine on twice a day. We're going to monitor your use of the medicine. So fill out this daily diary and bring the bottles back for us to weigh. So you could see we were totally honest with them. We told them we're monitoring, but we didn't mention the computer chips. And in their diaries, they said, oh, I used it twice a day religiously. And a lot of the patients almost never open the bottles. I mean, it's just striking how poor the use of topical therapy is. We did one long-term study where in the first month, the use of the medicine drops like a rock. And then after that, it stays down there around 10-15% of the time they're using the medicine for the rest of the year.
What is your advice on improving that issue?
Now, before I get to how you improve it, let me just say, if you've got somebody with horrible psoriasis and you give them one of those injectable drugs, which will clear them up, and they only have to do it once a day. No, did I say once a day? No, they only have to do it every 2 weeks. God, senior moment. They only have to do it every 2 weeks. Then they're going to take the medicine reliably, right? Because they're suffering. It's so easy. No, even they don't do it well.
You would think that they want the clear skin and want to feel better.
Yes. And one study showed that the worse the quality of life impact psoriasis had on people, the worse their adherence to treatment was.
Unbelievable.
It was almost as though the brain didn't want to think about the disease. It was so bothered by it, and they didn't use the treatment. We even did a study with the injectable therapy where we put those computer chips on the cap of a an injector disposal container and told people, throw it away in here, keep it sealed up real well, bring it back to us, we'll dispose of them properly. And we could see what people did with their self-injections. And the medicine was supposed to be taken every 2 weeks. Some people were going months between dosing. So there's a lot you can do to get people to use medicines better. And doctors have been going about it all wrong. Doctors have been blaming the patient. It's not the patient's fault that they're not using the medicine. It's the doctor's fault. Doctors are terrible about getting people to use their medicines. Doctors have this insane notion that what you should do when you want patients to go on medicines, you give them a prescription for the medicine, and then you tell them to use it, maybe educate them about it some, and see them back in 2 to 3 months. If a piano teacher gave kids sheet music and said, here's your sheet music, practice every day, I'll see you at the recital in 3 months, without having weekly lessons, that recital would sound execrable. I get to work with the most highly effective, most motivated people on the planet, and you'll know exactly who they are. They're medical students at the top of their medical school class who want a dermatology residency. They are desperate. They come to work with me for the summer. They want to publish. Do I tell them at the beginning of the summer, here's your project, work on this every day, I'll meet with you again at the end of the summer? No, because even these people would fail if you did that. I have weekly lab meetings with them to make them work. Doctors are the only people I know on the planet who say, do this every day, I'll see you in 2 or 3 months. It's totally our fault. We're worse than a piano teacher because we're like a piano teacher who says, here's a prescription for some sheet music. Take it to the sheet music store. I have no idea what it's going to cost. I want you to practice every day. Practicing could cause rashes, diarrhea, maybe a serious infection, but I want you to practice every day. I will see you back at the recital in 3 months. And if the recital doesn't sound good, well, we'll switch to a new musical instrument. I mean, this is ridiculous what we're doing. If I want a patient to take a medicine, I give them the medicine, I reassure them about it. I do little tricks, like if I want them to take an injection that's every 2 weeks, I don't tell them the injection's every 2 weeks, I tell them it's every day. No, wait, no, it's not every day, it's every 2 weeks. Because if I tell them it's every 2 weeks up front, their mind is thinking, I don't know if I want shots. If I accidentally, like I did earlier, say once a day first, then when I tell them every 2 weeks, they're like, oh, that's nothing. I can do every 2 weeks, no problem. The biggest thing I do is I give them my cell phone number and I tell them, listen, I want to know how this is working for you. Call me in 1 week and report your progress. That forces them to fill the prescription right away. There's a study that was done showing that half of the psoriasis prescriptions don't even get filled.
Wow.
This forces them to fill the prescription right away and use the medicine real well. Then when they call, I don't even have to answer the phone. My wife will tell you I answer the phone a lot of the time, but patients prefer if I don't. They leave me a message. It says something like, oh, Dr. Feldman, I am so glad you didn't answer the phone because it's Sunday and I really didn't want to bother you, but you said I had to call. You're right. It worked like a miracle. It's just been a few days and I'm like 90% better already.
Wow, incredible. See, you have this is what experience does for you. You have tactics and you know how to approach the situation. So are you concerned at all about these side effects or potential long-term side effects, I should say, that biologics might cause, like lymphomas or cancers?
For the most part, no. I think if you look at, say, serious infection rate on the biologic compared to the placebo group, you find there's no difference. It's like 1 in 100 get a serious infection with the drug, 1 in 100 get a serious infection with the placebo. It probably doesn't increase the serious infection rate at all. I wouldn't tell patients the risk is 1 in 100 because that'll terrify them. Instead, I like to tell them, 99 out of 100 don't get that. It's much more reassuring to think about it that way. Large studies, there was one study that enrolled 12,000 patients on biologics. And there were 4,000 of them, I think, were on Stelara. The rate of serious infections among the like 1,000 or 2 who weren't on any internal medicines for their psoriasis was basically 1 in 100 per year. And the rate of serious infections for the Stelara patients was 0.8 out of 100 per year. If anything, it seemed a little protective. When you look at heart disease risk, there's, I think, less heart disease risk in patients treated with those tumor TNF inhibitors like Enbrel and Humira than there were in patients who weren't on internal medicines. If there are side effects from these biologics, I suspect the benefits far outweigh the risk of the side effects. The drugs might prevent more side effects than they cause.
Interesting. So this might sound a little far-fetched, but before we end, I want to know, I get asked this often. Acne is such a common problem and affects millions of people around the world. And everyone asks, does my psoriasis, is it related to acne? Do I have to treat my psoriasis differently than I'm treating my acne? So is there any correlation, and do you ever suggest with a patient with acne treat their psoriasis differently, or have any concerns that you might say, avoid these products because it would flare your acne and it would be worse for your psoriasis, or vice versa?
Yeah, for the most part, I don't think there's any relationship between acne and psoriasis. I don't think there's any genetic relationship. I guess in theory, if you looked at big data, you might find some increased rates of acne in psoriasis patients or psoriasis in acne patients. And my guess is that would just come from the fact that if you go to a dermatologist for one, he's more likely to detect the other than if you don't go to the dermatologist at all. And so the relationship wouldn't be real. The other possibility is if you have psoriasis and I give you a strong cortisone medicine for it and you rub it on your elbows, and then over the course of the day happen to get that cortisone on your face, cortisone can cause some acne-like rashes to occur. I've seen that happen. But again, that would be uncommon. I don't think there's any direct relationship between acne and psoriasis.
Okay, thank you for that. Is there anything else we should cover today, or do you think we've hit the important points for
Oh, I
psoriasis?
think we've hit almost all the important points, except I want to reiterate something you mentioned earlier, and that's about the National Psoriasis Foundation. I say some crazy things. If you want really good, accurate information on psoriasis, I think the National Psoriasis Foundation is a great organization to seek that information from. I think you can join with a donation of whatever size you like. They have so much material for patients available for free on the web, information on all these new biologic therapies. And it's so easy to get to. You just go to psoriasis.org, not .com, psoriasis.org takes you there.
And I'm sure that's a great way to also advocate for psoriasis as well.
Oh, well said. If you're a patient with psoriasis and you want to make sure you have access to the new treatments, if you want to make sure research is being done to find a cure for psoriasis, I don't think there's any better way to do it than to support the National Psoriasis Foundation.
I'm with you there. So I want to thank you so much, Dr. Feldman, for joining me today at the Derm Club podcast. It was a pleasure having you, and a very insightful conversation we had about psoriasis. I hope this was helpful to everyone either affected by psoriasis or who wanted to know more about it. And I hope to work with you again in the future.
My pleasure.
Thank you
Thanks
so
for having
much.
me.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.